now let's review some of the structures of the eye and common pathologies. So let's start by reminding ourselves of the three layers of the eye, starting with the outer fibrous tunic, which consists of the sclera and the cornea. And the sclera is the white of the eye, and it is covered with a conjunctiva, which is continuous with the conjunctiva of the eyelids, of the inner eyelid. And then, of course, the cornea has no conjunctiva. It is clear, and it has no vascularization in it either. So this is what comprises the outer fibrous tunic. Attached to the outer fibrous tunic, of course, we have the 6 extrinsic muscles of the eye. We have the superior rectus, we have the medial rectus, we have the lateral rectus, we have the inferior rectus, which can be seen here. And then, of course, we have the inferior oblique, and it's cut, so it's cut at the medial edge. And then if we look at the top, we can see the tendinous attachment of the superior oblique, which attaches to the sclera. So remember, the superior oblique is going to arch medially, and then there will be a connective tissue sling called the trochlea. And the trochlea, as we recall, literally means pulley, and that acts as a pulley. When we look at the back of the eye, we'll remember that the optic nerve comes out at the back of the eye. Now, this is a left eye, so notice that the optic nerve is deviated medially or towards the center line of the patient, so the optic nerve will be then pointing posteriorly and towards the right, because remember, it's going to join the other optic nerve and cross at the optic chiasm. So now let's have a look at the second layer. And the second layer, called the uvea, also called the vascular layer, is going to be consisting of what we call the choroid, which is this brown part right here. So this is the choroid, and it's highly vascularized. So all of this is the choroid. And we also have the iris is part of the uvea. So the iris is the colored part of the eye, and that is what contains our two muscles that are going to control the pupil diameter, or the aperture of the eye. And so the pupil is what regulates the amount of light that is allowed to strike the retina and to pass through the lens, which is directly behind the iris and is where light will pass. So one of the things we'll see then is we've got two muscles within the iris, both smooth muscles. We have the sphincter muscle of the iris that is under parasympathetic control. As you recall, that's going to cause the iris to close. Then, of course, we have the radial muscles that are under the sympathetic division, and those are going to cause the pupil to dilate. And the pupil can become 6 times its size, from its most closed down size to its most opened up size. So that's quite a large range of movement that these muscles are capable of. So that's another thing to be aware of. Now when we open this up, we can look at another part of the uvea, and that is the ciliary body. So we look inside here and we see this structure here that's kind of this burgundy colored structure. It has a scalloped edge to it, and the scalloped edge is called the ora serrata. So everything from here, from this ridge right here, back to this scalloped edge called the ora serrata is called the ciliary body. And we have both ciliary muscles and ciliary processes. And the ciliary processes, as you recall, are going to contain suspensory ligaments, or they're going to be attached to suspensory ligaments, which then hold the lens in place. And the lens is the clear part of the eye that changes shape as the eye focuses. So when we look at the lens itself, as we have seen, is a biconvex structure, where the front part of the lens is slightly less convex than the rear part. So the rear part of the lens here is going to have a slightly larger bulge to it. And so as we have seen, that flips the image upside down and backwards. So as we know, when the image is focused on the retina, then it's going to be flipped upside down and backwards. So the ciliary body is all of this burgundy stuff here up to the ciliary processes here. And remember, we have those suspensory ligaments called the ciliary zonule, or the zonule of Zen, that's holding the lens in place. Now when we look anterior to the ciliary body, we see the back of the iris. And notice the back of the iris is quite dark. If we follow this around, we see that the ciliary body here, this burgundy color, is continuous with the choroid. And that in its entirety entirety is what is the uvea. So when we consider the ciliary body, the iris, and the choroid, that is the uvea or the vascular tunic of the eye. The third tunic of the eye is going to be the retina, which is this tan part right here. So the tan part extends from the ora serrata all the way to the back of the eye. And as we recall with our retina, the retina is comprised of photoreceptors called rods and cones, and that's the outermost segment, which is attached to the retinal pigmented epithelium, which is right next to the choroid. So the outermost layer, what we consider the outermost layer, is the part that is basically closest to the choroid and the sclera. The innermost layer is going to be facing the lumen of the eyeball. So we'll remember that our retina has the photoreceptors at the back, and then we have our bipolar cells, and then we have our retinal ganglion cells. And the retinal ganglion cells are the type of cells that actually conduct action potentials and have voltage-gated sodium channels. And so what we'll remember is the axons of these retinal ganglion cells, they will all course towards a spot at the back of the eye called the optic disc. And the optic disc is where these retinal ganglion cells all converge. That's this white spot here. It's kind of shown as yellow and white. And then we have these blood vessels emerging from it. And that then is what forms the optic nerve that comes out of the back of the eye. So the optic disc is where the retinal ganglion cell axons converge, and then they will exit the eye as the optic nerve. So those are the three layers of the eye. Now let's talk about some of the cavities within the eye. So when we look at the eye, we can see grossly that it can be divided into two cavities, a posterior cavity, which is basically everything behind, and I'll pull the eye out completely now. I'll pull the uvea out. So we can look from everything behind the ciliary process to the back of the eye. That is the posterior cavity. And everything forward of the ciliary process to the cornea, that is the anterior cavity. So if we look at it this way, the anterior cavity proceeds from here to here. And the posterior cavity proceeds from here to here. And the anterior cavity can be further subdivided into an anterior chamber, which is everything from the cornea to the iris. So this area right here, this is called the anterior chamber of the anterior cavity, and the posterior chamber of the anterior cavity is going to be from the iris back to the ciliary processes here. And so that's going to be occupied by the lens. So once again, we have our anterior chamber, our posterior chamber. Together, these make up the anterior cavity. Then we have our posterior cavity is the back part of the eyeball. So from the ciliary processes all the way back to the back of the eye, we have the posterior cavity. The posterior cavity is filled with a gelatinous substance called the vitreous body or the vitreous humor. And it's represented here by this plastic piece. But in reality, it is actually quite gelatinous. And as you've seen in one of the videos that we had earlier, that if you cut off the front part of the eye, then it kind of falls out as this big gelatinous mass. So this vitreous body helps hold the eye's shape. Remember, the eye is a hollow organ. And so, of course, in order to maintain its shape through various pressure changes due to altitude changes or going underwater or what have you, the vitreous body is part of what helps the hollow organ, the hollow eye, hold its shape. And it is present throughout the life of the person. It's not replaced. And it is typically a clear gelatinous substance. And certain pathologies can occur if you get opacities within this, and we'll talk about that in a little bit, but these are what we consider floaters. So floaters are a good example of pathologies that we see of the vitreous body. Now, the vitreous body is not the only thing that helps the eye hold its shape. We also have the aqueous humor, which is liquid, and it has a consistency very similar to cerebrospinal fluid, and it is produced by the ciliary processes. And it flows anteriorly through the anterior cavity, first through the posterior chamber of the anterior cavity, and then through the iris into the anterior chamber of the anterior cavity. And that also helps the front part of the eye keep its shape, but it also circulates around in the posterior cavity around the vitreous body as well. And we'll talk about several interesting pathologies that can occur in any one of these structures. So starting with the cornea, if we think about the cornea is one of the first of our clear refracting surfaces of the eye. It's on the exterior, it is in our fibrous tunic, and so light first must pass through the cornea and then through the pupil of the eye. And so if you get any kind of opacity on the cornea due to abrasions or scratching or infection or other things, then that can create an opacity through which light will not properly be refracted. And so this can also often be corrected if it's a infection. It can sometimes be corrected with eye drops or antibiotics. Sometimes abrasions will heal on their own. If there are serious clouding of the cornea, then the person can effectively be blind. There are corneal transplants that can be replaced, or I should say that can replace the cornea, so that the opaque cornea is then replaced with a new cornea. It used to be done with corneas from cadavers. Now, looking inside the eye, we can also see that we could have uveitis, which is inflammation of the uvea, or the vascular layer. We could also see that you could have problems with the lens itself. Now, the lens is made of a particular type of proteins called crystallins, and they are transparent, and they have no cell bodies or cell organelles. That's because they need to be completely transparent. So the lens can have sometimes cataracts appear, and cataracts often appear due to ultraviolet radiation, ionizing radiation, different age-related things that can cause cataracts, but cataracts are opacities within the lens. And cataracts are often treated, sometimes they can be treated surgically with lasers, but oftentimes the lens is removed and replaced. Now they use inert plastic. And so the inert plastic will sometimes, well, basically it's not malleable, so you can't really accommodate or focus. So once you have a cataract surgery or a lens replacement, then you're no longer able to accommodate because the lens is not pliable like a natural lens. So relaxing or increasing the tension on the suspensory ligaments isn't going to change the shape of the lens. So usually in this case, when someone has a lens replacement, what they do is they'll figure out the lens shape that would give that person 20/20 vision, and then they will use corrective lenses for near work or reading and these kinds of things. So that's another type of pathology that you can see. And then of course we have the vitreous body. And the vitreous body can sometimes get things in it like white blood cells. Sometimes the proteins within the vitreous body will crystallize, and then what will happen is that they will create these little dark spots. And what actually happens is they're creating little conglomerations or precipitate, if you will, with inside the vitreous body, and then that creates a barrier to light. And so it's just like having light hit an object in a clear sphere, then that creates a shadow. And what you're seeing then are shadows on the retina. So the vitreous body can have these things in it that are called floaters. And if you've ever seen floaters, most people will get them at some point in their life. They can be due to infection, and they can also be due, just as people age, to proteins that start to crystallize and form these crystals that when light strikes them, then they will create shadows on the retina. So another interesting pathology, usually that's not a big enough problem to do anything about it, and a lot of floaters will resolve on their own, but if they get bad enough and impede vision enough, then the vitreous body can be taken out and replaced, and that's a vitrectomy, and some people will have that done. It's fairly rare, but one of the other things about the vitreous body is over time, it tends to shrink with age, and the proteins, that the whole thing tends to dehydrate and contract, and usually it's pressed up flush against the retina, and that helps hold the retina in place. And so if the vitreous then is somehow detached, in the case of trauma, or even in the case of aging, as people get older, it will eventually start to detach itself from the back of the eye. And in most people, this actually is not a big deal. It's not a problem. You still have the aqueous humor circulating throughout here. But if you have a trauma, or if you have a sudden detachment of the vitreous, it can pull with some force, and it can also pull the retina with it. And so it can cause a retinal detachment or a retinal tear. Now, in a lot of cases, people will have vitreous detachments, what we call a posterior vitreous detachment, where it doesn't pull the retina with it. and eventually the vitreous will peel right off the back of the eyeball. And in most people, this happens with age, so around age 60 or 70, this process starts to happen. In some people, it can start earlier. It can be precipitated by trauma, where you can actually see a posterior vitreous detachment where it has started to pull away from the eye. For example, if someone has a sudden hit to the eye or some other thing that causes the vitreous to start to pull away from the back of the eye. In most cases, it does not do immediate damage, but if you have a abrupt enough pulling away from the eye, then the retina will sometimes be pulled with it. It can be detached. It can cause little tears or even little punctate holes within the retina, and that becomes problematic because then the fluid, the aqueous humor, will circulate behind the retina and start to pull it off the retinal pigmented epithelium. So remember that our photoreceptors are the outermost, so those are going to be the ones that are going to be flush with the retinal pigmented epithelium, which is right next to the choroid. And the retinal pigmented epithelium is essential for maintaining the rods and cones, or our photoreceptors. So if the retina gets pulled off of that retinal pigmented epithelium, then eventually that part of the retina will be deprived of nourishment and it will die. So this is a problem that needs to be corrected very quickly. And a lot of times some of the symptoms of a posterior vitreous detachment without a retinal tear is the patient will see kind of these circular flashes of light that are usually black, yellow, or white around the periphery of their vision when they move. And that's because as the eyeball is moving, the vitreous is sort of bouncing around back there. It's no longer attached to the posterior part of the eyeball, and it's kind of pulling the retina along with it. And eventually it will peel the rest of the way off, so it's kind of free-floating in there and it's no longer pulling on the retina. And in the cases where you have extreme pulling, then yes, you'll see other symptoms where you'll see something very similar to a migraine aura, where you get these very neon bright flashing, sometimes curtains of light, as the retina is detached. If it's completely detached and folded over, then there will be a shadow. That sort of, it's like a curtain waving around in the person's vision. And remember that vision is inverted and flipped sideways, or flipped the opposite way around. So if the retinal detachment is in the lower part, then the person's going to have an upper visual defect, because remember that the upper part of the visual field is refracted into the lower part of the retina and vice versa, and left is flipped to right and so forth. And this is corrected by our brains through the visual pathways. Now, another thing that's interesting to note is that people who have myopia and they have very long oval eyeballs, they will be more prone to retinal detachments, especially with older age. And there's some case studies where people have done things where they lean forward for long periods of time. For example, there was a case study where a woman was a fairly older woman and she had very bad myopia, and she leaned forward in what was called downward dog for about 2 minutes. And this is a yoga pose where you're facing the floor and you're sort of in a piked position. In any case, after about 2 minutes, some hours later, she started to notice the symptoms of a retinal detachment. And what had happened was that the fluid within the eye pulled forward and the vitreous body pulled forward and pulled the retina along with it. So these are some of the problems that you can see, pathologies, mechanical pathologies of the eye. There are various kinds of pathologies that you can see with the eye. These are just some of a few. Of course, we also have within the retina itself, we've got several types of pathologies that can occur. So remember that we have the visual axis of the eye points right to, or I should say, basically will fall right on this area right here. It's a sort of pink area that I don't know if you can see it, but the pink area there labeled 13, I believe it is, that is called the macula lutea, and it's apparent on a fundus exam. And the macula lutea, right at the center of it, contains the fovea. And this is where you have the maximum, the best, highest acuity vision. This is where you have the maximum concentration of cones. As we recall, cones are specialized for seeing color, and they are what they have the smallest receptive fields. They usually have a 1-to-1 convergence, or in other words, there is no convergence. They have a 1-to-1 connection with their bipolar cells and their respective retinal ganglion cells. So they have very, very small receptive fields. You have very small receptive fields in this area, in the macula lutea and the fovea, and that allows for our highest acuity vision. This is where we would have like our 40 megapixel vision, if you will. And as we go out more peripherally, we have fewer and fewer cones and more rods, and the rods are specialized for seeing low light conditions. They see only in black and white, and of course they also are specialized for motion detection, but they have very, very large receptive fields. And so the vision in the periphery is about 2400. And so that means that they have very poor ability to distinguish form and zero ability to distinguish color. But what they are very good at is detecting movement and edges and in very low light conditions. And so when you think about what happens if something flashes by in the periphery, then that's going to get the attention of the organism, because these rods are very good for detecting low light, in low light conditions for detecting movement, and then that will cause the person or the organism to turn immediately, head or eyes towards whatever was moving in the periphery, and then the organism can foveate whatever they saw in the periphery so that they can get a good idea of what it was, and then there they can distinguish form. And if the particular organism has color vision, as humans do and primates do, they can distinguish color as well. So cones distinguish form and color, and rods distinguish only black and white, but work in very, very low levels of light, whereas cones do not. And rods also have the ability to detect motion. And when we look at receptive fields, we'll see why that is. Now, the macula lutea is also sometimes prone, especially in elderly people, to macular degeneration. And this is where the person will lose the photoreceptors in the retinal cells in this area. And what happens is over time, this can happen. There's both wet macular degeneration and dry macular degeneration, and this, both of which are just basically loss of these photoreceptors here. And wet macular degeneration, it occurs because there is an ingrowth of blood vessels into the area that then break, and then they sort of, basically you have sort of a hemorrhage in the eye that causes the loss of these cells here. And in the case of macular degeneration, that the patient loses the central vision. They lose high visual acuity. They lose a lot of their ability to detect form and color. And depending on the severity of the macular degeneration, usually it starts as kind of a waviness of the central part of the vision. So lines will be warped there, things will be warped. The image is a little bit distorted, and then as it progresses, it turns really in sort of a gray nothingness or miasma. On the other hand, you can also have loss of peripheral neurons and peripheral photoreceptors. And a lot of times what happens in a condition called glaucoma, you have too much pressure buildup in the eye. And that is usually because you're making too much aqueous humor. Now, aqueous humor is replaced. So it drains out through an area called the scleral venous sinus, which is right on the, sort of right around the cornea here. And the scleral venous sinus allows for excess aqueous humor to be drained from the eye. And in the case of glaucoma, a lot of times the aqueous humor cannot drain from the eye because it's blocked. Either the eye is making too much aqueous humor, or the canal of Schlemm, this scleral venous sinus, is blocked in some way. There's several types of glaucoma. There's open angle and closed angle glaucoma. And I'm not going to get too much into that, but suffice it to say you have increased pressure of the eyeball. And what that does is the increased interocular pressure puts pressure on the retina. And one of the things that's almost immediately obvious is when we look at the optic nerve and the emergence of the optic nerve at the back of the eye, we see there's a break in the sclera. In fact, the eyes are really an outgrowth of the brain. And so you have an area, you have dura mater, and you have a subarachnoid space that surrounds the optic nerve. And it's actually an extension of the brain. So you have cerebrospinal fluid flowing through here. And that will bring me to another type of pathology we'll see in just a moment. But in the case of glaucoma, what will happen is the easiest place to relieve pressure is at the back of the eye, where you have this break in the sclera. And that would be where the optic disc is. And so some people with glaucoma will exhibit something called a cupped optic nerve, where the optic nerve is being pressed inward because of this excess pressure in the eye. And excess pressure is usually considered above 25 millimeters of mercury. And this is measured with a little tonometer that they can put on the cornea of the eye, and they can measure the pressure of the eye. And so when it gets above about 25 millimeters of mercury, then there's excess pressure. It usually is relieved by pressing on this optic disc and also pressing on the neural structures of the retina. And typically the vision loss is from the periphery inward. And so a lot of times if patients, and this is particularly, I should say diabetic patients are particularly predisposed to developing glaucoma, so they should be checked often. But the vision loss will start in the periphery. And a lot of times if you have a cupped optic nerve, you'll see that the cupping of the nerve is very shallow at first and then gets worse over time. But the cupped optic nerve will then progress, and basically they'll start losing their peripheral vision inward. And then if it's not treated quickly enough, then the person will go blind completely. And so the cupped optic nerve is a telltale sign of glaucoma. And one of the things that can happen then is they can relieve the pressure one of several ways. They can give eye drops to slow the production of aqueous humor. They can also sometimes put a stent in there, find a way to drain the aqueous humor a little bit more readily. But typically, a lot of times glaucoma is very treatable, and when it's caught early enough, then the patient usually suffers minimal vision loss. If it's allowed to continue, this is why education about glaucoma is so important. So if glaucoma is allowed to continue, it will eventually cause loss of the entire visual field. Now, going back to what we were talking about with the optic nerve is bathed in cerebrospinal fluid. So the optic nerve can also, if you have high intracranial pressure, where you have too much cerebrospinal fluid, or you have an infection and you have an accumulation of cerebrospinal fluid within the optic nerve, that too can cause problems. And that can cause too much pressure on the optic nerve, and that can damage the optic nerve. And you can even get papillary edema, where you have swelling of the optic nerve. So that is another common pathology that is seen in the clinic. So some of the other pathologies that are maybe not as severe, for example, conjunctivitis. It's usually where you have an infection, or a lot of times you see this as blood vessels quite red, that's pink eye. You have infections and other problems that cause the conjunctiva to become inflamed. And remember, the conjunctiva affects the sclera, but not the cornea. So very quickly, we've had the opportunity to review some of the structures of the eye, and we've had the opportunity to review some of the common pathologies that are seen in the eye.